Good afternoon and welcome to July's quality webinar. We appreciate you joining us today as we talk about inpatient and outpatient chronic condition coding. The struggle is real. Before I pass this over to today's speakers, I just want to go over a couple interactive areas that you have in this On24 platform. This is a web-based platform, so there is no dial-in number. You are joining through your speakers, so if you do have any issues, check your audio settings. Doing a quick refresh does typically fix any of the glitches that there might be. In the media player, if you do need closed captioning, we do offer that capability. There are a couple other sections to keep in mind. We have the Q&A box. Please ask questions. We'll get to as many as we can at the end of this session, and we'll follow up with questions after if we don't get to them. We do have a resources section that does have today's presentation as well as a certificate of attendance. This is not for CEUs, but you can use this certificate to submit to an accredited association. As well as the presentation slides. So make sure you download those ahead of the end of the session just so you have them. And then at the end of the presentation, we always like to hear how we did. If you could complete the survey, we really appreciate that. So as you can see here, if you've been on our quality webinars before, these names shouldn't be unfamiliar to you. These are some of our great subject matter experts. Audrey Howard, Bobby Starkey, and Dr. Beth Wolf will be joining us today. We appreciate you all joining, and I'm going to go ahead and pass it to our speakers.
Excellent. Well, thank you. We're starting at the bottom of the list with Dr. Wolf there. I'm in excellent company today. These are two folks that I have on, I guess it's not speed dial anymore, Teams dial for all questions coding. So happy to be participating with them. The objectives for today, I think, we all understand the importance of coding accuracy. We're going to be focusing on how we report chronic conditions. And, I'm going to start with kind of the shock value, right? The audits and the dollar values, because I think we see that in the news, but also, talk about some of the very real patient impact as well. It wouldn't be a talk about coding without going over the coding guidelines. And in this particular instance, inpatient is very different than outpatient. And I think it certainly trips us up. We'll look at some case examples that we think have been challenging for us. We hope you agree and post your questions and ideas. And then as we go through the cases, we'll talk a little bit about, how we identified some of these issues and really how do we, educate our coders and our providers so that we are as compliant as we need to be. All right, with that, the shock value, right? The impacts of incorrect reporting in chronic conditions. Of course, this top one, unfavorable audits with paybacks. I'm going to have about 4 slides that will catalog some of the things we've seen in the news. These are time-consuming. They're terrifying. Requires, corrective action plans. Nobody wants to go down that path. The second impact, and I think maybe we don't talk about it as much because, it's anecdotal in many instances, but what we attach to our patients' health history, follows them. And I think, that patient-centeredness is extremely frustrating when we have these perpetuated inaccuracies. And then, obviously quality outcome interpretations, and as we move from volume to value, that also has financial implications. So again, many downstream effects for incorrectly reporting these chronic conditions. As I promised, again, the dollar value here in 2021, CMS recouped $223 million in overpayments from our Medicare Advantage plans. And again, these are, not unexpected audits that they're facing, but they go in the record and they find diagnoses that were reported that impacted reimbursement that did not seem to be supported as reportable diagnoses based on the coding guidelines. Again, I'm going to go through these pretty quickly in the interest of time, but you'll have them in your slide deck. The common theme is, again, we're not following the coding rules and guidelines when it comes to reporting these chronic conditions. And these happen to be, outpatient claims. So again, we're going to focus a lot on outpatient. I'm going to stop with these, but you'll have them for your reference. And just tell you, what I think we should be preparing for. I mean, there's no question that, this is going to continue. The DOJ has the authority to recover 3 times the overpayment plus a big number per violation if it falls under the False Claims Act. I mean, this is, huge. And I mean, they're getting money back. They're finding errors. From a health plan perspective, they know they're going to be subject to these reviews. Their main goal, the UPIC auditors, is to identify, investigate, and mitigate fraud, waste, and abuse. Okay, so under the microscope. And, they can identify the common diagnoses as well as we can, right? So they're going to be targeting reviews. And, of course, with that extrapolation, makes it very concerning. Now, I was asked, how's that going to affect my physicians, my APPs? I mean, certainly, we don't want to fall under any category of fraud. We want to report things that are only accurate. We are not coders, though. We appreciate that. Many of us do our own professional billing, but oftentimes, we have professional coders helping us. So a little bit of variability there. But most certainly, if you're part of a Medicare Advantage plan or a larger health system, I would expect more prospective audits, right? We're trying to get in front of these and use our findings to educate. So with that, I'm going to turn it over to Audrey to take us through the official coding guidelines.
Thank you, Dr. Wolf. And yes, we are going to go into this because we see that there are issues that are out there, and to make sure that we are complete and accurate coders, we need to make sure that we are following the guidelines and any official advice that is out there. So we want to lay that foundation as to what is the available guidance that we have available. In our official coding guidelines, they do have a section in there for the coding of secondary diagnoses. And what is included on these next couple of slides are the entire coding guidelines related to the secondary diagnoses, and it's verbatim that's in here. We have highlighted what we believe is to be the most important parts as it relates to the coding of chronic conditions. So first here, you see that the guideline provides us with the information that makes that secondary diagnosis reportable. In summary, it needs to meet one of these 5 criteria highlighted here. And like I said, one of the 5. So it doesn't need to meet all 5 or 2 or 3 of them, just one of them. Was it evaluated? Was there treatment? Was there a diagnostic procedure going towards it? Did it extend the length of stay, or did it increase nursing care? But I also wanted to emphasize here the sentence which states diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. In other words, even if a condition is documented by a physician, it doesn't necessarily make it reportable. It has to meet one of these criteria. Going on to the next slide, it goes into the 3 subsections, if you will, of the secondary diagnoses. And the one that was really most important here is the first one on the previous conditions. Once again, it is stating if a condition has no bearing on the current stay, it should not be reported. So the key here is to verify that the condition is reportable and it has a bearing on the current encounter. The abnormal findings, and then this last section on uncertain diagnosis, I mean, it is a part of the secondary diagnosis guideline, but it's not really pertinent to our topic today of coding of chronic conditions. So that's the official coding guidelines as related to the inpatient setting. So let's talk a little bit about some of the coding clinic advice, once again related to the inpatient setting. And there was a coding clinic that was on the clinical significance of obesity. And as you see here, it's from 2011. And it's stating that individuals who are overweight, obese, or morbidly obese are at an increased risk of certain medical conditions when compared to persons of normal weight. Therefore, these conditions are always clinically significant and reportable when documented by a provider. Once again, this is, and Bobby's going to go into more detail on this from the outpatient setting, but from the inpatient setting, if obesity, obese, morbidly obese is documented in the inpatient setting by a provider, then it can be picked up. And then, if the documentation does include obesity, obese, morbid obesity, then the BMI also is reportable. It's also clinically significant, so it can be picked up. Going on to another coding clinic, and this one is from 2007. And this coding clinic is going to be referred to a couple of times during this presentation. It was originally being addressed related to the code assignment for COPD. But the advice does go on to state that there are a few chronic systemic conditions which include, but are not limited to, hypertension, Parkinson's disease, COPD, and diabetes that should ordinarily be coded even in the absence of documented intervention or further evaluation. So these chronic conditions affect the patient for the rest of their life and almost always require some sort of continuous clinical evaluation or monitoring during hospitalization. Notice this part is very specific. Everything above this applies to inpatient coding. So since the answer states, but not limited to, what are the other chronic systemic conditions that could be added to this list? And, we don't really have this answer for you. It's something that we recommend that you work with your medical staff to develop this list, to say, what are those chronic systemic conditions that could be added here that could be reportable. Now, if there is contradictory information within the record, you should query for clarification. So it's important to pick these up because not all of these chronic systemic conditions are going to be CCs or MCCs that can impact your DRG assignment, but they could impact risk adjustment or other quality metrics. So the best practice, though, even with this information, is to be able to work with your providers, with your physicians, and have a good understanding as to what is needed to include relevant clinical indicators in the physician's documentation for every diagnosis, because that would help prevent any future denials on this case. Now, as this stated, this top part and this part of the slide from 2007 advice is only related to inpatient coding. So as we go on to the next slide, I'm going to turn it over to Bobby to talk about the outpatient portion of it.
Thank you, Audrey. Yeah, so this particular coding clinic, it's a chronic condition coding clinic advice, and they start off with their response, and then they say, this is based or pertains to inpatient visits only, and then it goes on to say right in the middle of the coding clinic, for outpatient encounters or visits, chronic conditions that require or affect patient care, treatment, or management should be coded. And then they reiterate the official coding guidelines for reporting for outpatient services and what that guideline states. And then the very last sentence states, conversely, conditions that do not require or affect patient care, treatment, or management are not reported. So this one coding clinic kind of shows the differences between inpatient reporting of chronic conditions and outpatient reporting of chronic conditions. So this particular slide is just the official coding guidelines for reporting for outpatient coding, section 4, letters I and J. And like Audrey said, we've highlighted, it's all important, but we've highlighted what's important to what we're talking about today. So those are our official guidelines for outpatient reporting of chronic conditions and coexisting conditions. And then moving into some of the coding clinic advice that was posted regarding reporting of chronic conditions for outpatient and some of the confusion that these coding clinic advice, what they've caused. So this first advice is from Coding Clinic 3rd quarter 2019. It's a question that was sent in regarding a patient who's coming in for hernia surgery, and the provider has documented Crohn's disease, and that this patient is on immunomodulating drugs for the Crohn's, but the patient didn't receive the drug on this current surgery visit. So the writer wants to know, is the Crohn's reportable even if treatment is not occurring on the current visit? The response that the AHA gives is yes, it's reportable based on the documentation submitted. Now, unfortunately, we don't see the documentation that they see, but it says that the provider has specifically stated that the patient's receiving treatment for the Crohn's disease. The ongoing treatment doesn't need to occur during the current encounter. The fact that the patient is undergoing treatment for Crohn's disease affects the patient care and management. So keep this coding clinic in mind, because we're going to refer back to this case a little later in our conversation when we talk about some of our examples today. And then this coding clinic came out a year later, third quarter 2020, and to me, it muddied the water a little bit. It was a question regarding a patient who came to the ED, was seen for a sore throat. The patient had multiple behavioral health conditions documented in the past medical history, and antipsychotic medications were listed for the patient in the med list. And they asked, would these conditions be reportable if there was no documentation to support that the physician monitored, evaluated, or treated the patient for any mental health disorders during the ED encounter? And the response that coding clinic gave was no. And they go on to say, unless the provider indicates that these conditions, and then the really important part of this sentence is, or any other condition, affected the management of the patient during the current visit, the mental disorders would not be coded and reported. So they clarified for us that the advice in this coding clinic isn't just pertinent to mental health conditions, it is pertinent to any other condition. And then coding clinic, I guess they must have got a few questions. They came out with a clarification coding clinic. I'm sure the person writing in had the same questions that we all had regarding the two previous coding clinics, like how are they different? And I don't think coding clinic did a great job of clarifying this here, but the important thing to glean from this slide or this advice is the first part of the response. Coding professionals should not assign codes based solely on diagnoses noted in the history, problem list, and or a medication list. It's the provider's responsibility to document that the chronic condition affected care and management of the patient for that encounter. And then the last sentence in the response, if the medical record's unclear or ambiguous regarding which condition or conditions affected patient care and or management of the patient, query the provider for clarification. So when this advice, this clarification came out, it probably changed the way many of us were looking at the chronic conditions up to this point. I've included this coding clinic advice. It's pertaining to HCC reporting and its clarification, but it kind of fits in here, and I want to make sure that people who, I've heard people say, I'm not a risk adjustment coder, so, I'm not really worried about this, but what the response that the coding clinic's giving here is the difference between HCC coding or risk adjustment coding is that the risk adjustment coder is going to look at all the encounters over a period of time, and they're going to be able to look for an HCC or a chronic condition that supports an HCC out of all those visits. But those single visits that are getting coded by medical coders still have to have documentation to support those conditions, HCC conditions. So if you're risk adjustment coder or not, it doesn't matter. Those are official coding guidelines, so we should all be following those. The difference is just going to be what types of accounts or the timing of the accounts that you're looking at. And then this is just a summary of all the inpatient and outpatient coding advice and guidelines that we just gave. So you have them all in one place if you want to refer back to them. So now I know everybody's super busy, but I'm hoping that we can get more people to write into Coding Clinic to get more advice on coding of chronic conditions in outpatient. Outpatient, a lot of the guidelines are based on inpatient coding. They're things that you see in an inpatient environment. Outpatient's really not been so robust up till now. It'd be nice if we could get some additional guidance. So I'm going to hand it over now to Audrey, and she's going to tell us how to submit a question to Coding Clinic.
Yes, because it is important to submit these questions to Coding Clinic. And as Bobby was saying, if we are having a lot of questions from the outpatient side, let's get those outpatient questions submitted. And the more questions that are asked, then the more likely that they will publish them in Coding Clinic. And we then have some official advice. So it's really simple to do. And these next couple of slides are going to go through some screenshots of how you can do create an account and then submit those questions. So you go to www.codingclinicadvisor.com and you click on create an account. You put in your information. And once you get your account created, create your password, then you can start submitting questions. And you click on the submit a question icon and you agree to this. I recommend highly reading through all of these submission guidelines, because if you do something or break a rule, if you will, then your question will not get answered. It will come back unanswered. So read through this, click on I agree to this information, and then you can say, what type of question is it? ICD-10-CM or PCS? And PCS? Is it ICD-10-CM only, PCS only, HCPCS code? You create a title. You do have to be careful on your the length of your title, because it has a restriction on the number of characters you can use, as well as your question that you're using. Now, typically, I'll come up with a question, and then my question will be abbreviated here because I will be submitting documentation, I'll click on choose file, and I'll have like a Word document that I'll also add in there so I can expand on my question. I'll include in there information, lots of good medical record documentation, H&P, discharge summary, path report, op note, always making sure you get rid of all the protected health information from there. Or that can kick back. And then you can click on submit my question, and then you patiently wait. And the responses could take up to a year to get back. And especially if we're going to start flooding Coding Clinic website with more questions, it can take some time. And then good news, bad news, your question may get referred to the editorial advisory board. I call that good news, bad news, because bad news is you don't get your answer back right away. You have to continue to wait while it's going through the EAB review of it. But the good news to that is that means there's a higher probability that your answer would be published in Coding Clinic, thereby making it official advice. Because that letter that you get back from Coding Clinic is an individual letter that is meant just for you, that cannot be shared, and it's really not official advice. So we have to be careful with the answer that we get back to make sure that we are still applying it appropriately to all on future cases that may have the similar situation that your letter was about. And always remember, when you are submitting information, that your documentation does not include the protected health information, no PHI, and that does include any hospital names and provider information. I have often got a letter kicked back to me that's going to go unanswered because there was not enough medical record documentation. They wanted more. All of the discharge summary, the progress notes, the path report, everything, any consults that's related to it. So you want to make sure that you're giving enough information in there. And then be careful with the sorts of questions that you're asking. They're not just going to, if you say, what's the principal diagnosis for this case? Well, they're not going to answer that question. And they're not going to code an entire record or an entire operative report. They would want to know what your specific question is. What's the root operation, or what's the body part, or what's the approach, so that they're not, so it's kind of honing into what is your main point about what you're asking about. Don't ask questions on payment issues or DRG related questions. What they are specifically going to address is what's the correct code assignment for something. So those are some things to keep in mind. And before I pass this over to Dr. Wolf, I did want to address one question that came in regarding that coding clinic from 2011 that was on the, I was talking about clinical significance of obesity and morbidly obese. Yes, that did also include in that coding clinic about overweight. So according to the coding clinic, overweight, obese, or morbidly obese, if that's documented by the provider, then that would be considered always clinically significant, once again, in the inpatient setting. And thank you very much for submitting that question. Hello, my friend. And now I will pass it over to Dr. Wolf.
Thank you, Audrey. So now we know the rules, or we think we know some of the rules. There are several challenges to reporting these accurately. And of course, I'm going to speak from kind of the physician perspective and focus on the documentation. But when I look at these charts and I look at, these audits that have resulted in big takebacks, there's a common theme. And the theme is that the diagnosis in question of the condition isn't really linked to the medical decision-making. And, I know MDM, medical decision-making, is kind of how the physicians now think about their professional billing, so I'm sort of bridging that gap. But when we talk about, is it monitored, evaluated, assessed, treated, increased nursing care, increased monitoring, affects how we care for the patient, that really, in my mind, kind of rolls up to medical decision-making. So I think that's, key language that I use with the physicians when I'm talking to them about what they should document and why. Now, this is a HEMA practice brief, so I encourage you, great resources via HEMA and ACTIS, but it does talk about documentation and coding practices for risk adjustment and HCCs, our hierarchical condition categories, and they go through, some physician ABP documentation best practices, and, on the inpatient side, we're always talking about cause and effect. Absolutely translates to the outpatient side. What do you care about? Okay. And, with the outpatient rules, that really falls on the physician and APP to talk about, to really kind of solidify it as a reportable diagnosis. Now, they do talk about some organizational policies that can help address risk adjustment coding. And a lot of it has to do with, really kind of, reviewing those records, making sure that we're auditing ourselves, making sure that we're very clear about history of versus an active diagnosis. And so, again, I'm not going to go through each of those, except to say, this is where it becomes so important. We have these practice briefs. We have to have our own, internal policies that we follow, and an understanding of how we as healthcare systems and clinics are going to approach this. This comes up, NEAT. So NEAT is not supported by any ICD-10 CM official coding guidelines or reporting guidelines, but it is a pretty handy tool, and it rolls off the tongue. And I think coding professionals kind of have, ingrained that in my thought process. And so I kind of continue that language with my physicians, again, really, thinking about what is it that I care about. And not everything, has to be stated necessarily, in the assessment and plan and repeated over and over again, but somewhere within that, the entirety of the note, there has to be some inkling that, I care about it and that it's impacting the care provided. So this is exciting. Now that medical decision-making is a bigger part of our professional billing, right? So we get to kind of level our E&M billing now primarily based on medical decision-making versus ticking off bullet points of certain exam and review system addressing. So, this is great, right? We understand it as physicians. It's how we get paid. It absolutely reflects complexity. If you look at the evaluation and management coding guidelines, when they talk about medical decision-making, this is great for the coders who are trying to figure out what the physician cares about and what's reportable, right? So, when I bill for my patient visit, I'm looking at the number and complexity of problems. I'm, talking about what I've treated, what's impacting my prognosis, what I'm going to follow up on. And these are all things that relate back to being a reportable diagnosis. And then obviously the complexity and amount of data and risks, right? The risks associated with something. Okay, I may not actively be treating it, but if it's factoring into my risk assessment for the patient at the bedside, I'm gonna take credit for that. Now, kind of straddling, both arenas of inpatient and outpatient, there are rule differences, but there are practical differences as well, which I think makes this difficult. On the inpatient side, one of the easy things is that we get to see the patient multiple times. Okay, usually, and there's multiple specialties, right? And they bring their own, set of vocabulary into the picture, right? We get lots of detail often. On the outpatient side, it's a single visit and it's 15 minutes, right? Potentially. Okay, so again, we, don't have the luxury of so many contacts and really so many physician APP notes to look at. Now, this one, the reportability compliance on the inpatient side, right? I'm not going to say it's necessarily easier or different, but remember, I can look at nursing notes, I can look at dietary notes, ancillary notes. They're all part of that encounter, right, to support the reportability of that diagnosis. On the outpatient side, it's kind of one provider, right? And, it is harder to kind of validate reportability for everything in the problem list or the diagnosis list, okay, if they're not pulling into their assessment and plan. And then lastly, on the inpatient side, coding the inpatient chart, we have professional coders, hired to translate, right? So it's a very consistent team of people reporting. On the outpatient side, we may have those professional coders, but there are a fair number of physicians and APPs who do their own diagnosis selection and E&M billing and leveling. So again, different constructs in how we have to approach this, I think. Okay, I'm going to turn it over for case discussion.
Thank you, Dr. Wolf. So we're going to start with some outpatient scenarios. We want to trigger some discussion around what chronic conditions are supported by the documentation in these cases. And just a reminder, so we won't be giving guidance as to the correct way to report these scenarios. They are really just for discussion. And we want everyone to keep in mind that in coding, all coders know that each case stands on its own. So we're going to start with a little bit more a simpler case. This is a wound clinic visit. The patient has some additional chronic conditions documented in the note. So clearly the wound was documented and treated. We're going to pretend there's a depth of the wound also documented so we can report this to the greatest level of specificity. In the past medical history of the note, our provider documented paraplegia due to a C6 injury after a fall from a ladder. In the body of the note, the provider documents that the patient's having trouble repositioning himself as he's alone most of the day. So my first question is it going to be appropriate to report the code for the paraplegia for this visit? Is there clear documentation that supports that the paraplegia requires or affects patient care, treatment, or management? So our official coding guidelines for outpatient, section 4J, says code all documented conditions that coexist at the time of the encounter or visit and that require or affect patient care, treatment, or management. So that note where he says the patient has difficulty repositioning himself as he's alone most of the day, is that enough to support that this paraplegia impacts the patient's care or treatment? And then my next question, would it be appropriate to report then the sequela of the injury? So if the paraplegia is going to impact the treatment, and the paraplegia is actually a sequela of the injury, we're not treating or monitoring the injury, but does the injury impact? So would we code one of the, either one of these, would they be reportable? And then if the provider had not documented that the patient's not able to reposition himself, would it change how we would respond to those two above questions? What would better documentation actually look like here? So I'm going to ask Dr. Wolf first to weigh in on her thoughts from a provider standpoint, and then Audrey, if she wants to provide any additional thoughts.
Okay, well, this is this is Dr. Wolf. I think I look at this case different each time we read through it. So, I think the paraplegia due to this C6 injury is reportable, and I might get some pushback on that. I would assume, and we know what that means, but they've talked about the impact on mobility, and they've given, at least in what we can see here, no other reason for that mobility problem. So I think that in the totality of what I see, it is supported as a diagnosis that is impacting care. So that's the first thing. The second thing, I don't know in what I see here that I can automatically link the wound to the C6 paraplegia, although I might be able to talk myself in a circle around that. Obviously, ideal documentation, linking cause and effect directly would be, what I would want to see. And Audrey, I'll let you chime in.
Sorry, trying to find my unmute button there. I know I'm the same with you, Dr. Wolf. I always have a difference of thinking about this every time that we go through this. I just want to bring up about the paraplegia. I know that there was a recent coding clinic that was relating the paraplegia to a previous injury, that it would be included in the actual traumatic injury code. So I'm just thinking from a coding standpoint on that. Now we still have to address, is it something that we can pick up as a secondary diagnosis? I mean, from an inpatient setting, obviously we have additional documentation that, from nursing notes that would be able to say, is it increasing nursing care? From an outpatient standpoint, we don't have that luxury, if you will. So I think this is something that you have to look at all the documentation, see what's available on these types of cases.
Thank you both. Yes. So we're going to move on to the next example. So this is outpatient scenario number 2. It's a little more difficult. This documentation is provided by the anesthesiologist on their pre-procedure note. In the past medical history, the anesthesiologist documents COPD, GERD, and hypertension, and a history of a CVA and current smoker of cigarettes. In the current med list, they document Symbicort, amlodipine, and omeprazole daily. There is no other documentation regarding these chronic conditions in the surgeon's notes. So the ASA score that's assigned by the anesthesiologist is documented for this case as a 3, which means the patient has a severe systemic disease. So the first question, would the COPD, GERD, and hypertension be reported? The history of CVA in 2017, would that be reportable? And then again, what would reportable documentation look like? And I know, Dr. Wolf, you want to talk a little bit about the ASA risk assessment here.
Yeah. So I'm going to jump forward. Yeah, thank you. So this is a small print. Hopefully you've got a big screen. I'm going to blow it up a little bit under ASA 3, but for those of you who don't know, this is a physical status classification that is almost universal across anesthesia, and it addresses adult and pediatric and OB examples. And they have the classification, and then the definition, as we said, 3 was severe disease. And then if we look at a little more detail, and this is just blowing up that classification 3, severe disease, you can see they give some examples. Now, they say including but not limited to, right? So I'm just going to kind of go with the fact that, if we're going to use this table, in my institution to decide what we're going to report, we're going to, limit ourselves to what's in this table, and potentially maybe my anesthesiologist may have a longer list. But in ASA 3, right, so we have functional limitations, 1 or more moderate severe diseases, poorly controlled diabetes or hypertension, COPD, morbid obesity, active hepatitis, alcohol dependence or abuse, pacemaker, reduced EF, end-stage renal disease, history of MI, CVA, TIA, or CAD. So if you'll remember, our patient had documented COPD, GERD, hypertension, and a history of CVA and current smoker. So, when we're talking about kind of using tables, and I know this, isn't a formalized precedent for ASA, but we certainly, use descriptions of fractures and things like that to assign codes based on how it's described. I would feel pretty comfortable picking up the diagnoses that correlate with this anesthesiologist's medical decision-making assigning a level 3. And so if you want to hop back to that original case, we can look at that. So they don't say that things are poorly controlled, but that history of CVA certainly falls into kind of the, ASA 3. And then if we take that coding clinic to the bank that you shared with us about, diseases that stay with us for life and impact us, I would consider, reporting the other ones. And then certainly, even though this is an outpatient scenario, I do have more than, one physician seeing the patient, and now I have nurses. So are they monitoring the blood pressure? Are they, giving medications for any of these things? I think, most of those, certainly COPD, hypertension, and history of CVA would be reported even under the strictest of rules.
Perfect. Thank you, Dr. Wolf. And I also think, Dr. Wolf talked about the clear linkage. So if a facility can utilize their electronic health record and type in, have some sort of a header as part of the template that says something like the conditions listed below were used to calculate the ASA risk score, based on the American Society of Anesthesiologists physical status. So that would be that clear linkage from the ASA risk score, so the treatment, to the conditions. And then, if the documentation looked like hypertension well controlled with amlodipine or GERD well controlled with omeprazole, in that case, would it be acceptable to report the hypertension and GERD in that situation? And I would say yes, because the physician has linked the hypertension to, he's assessed it and said that it's well controlled with that medication. And then moving on to the third example that we have. So this is a patient that's presenting for a hernia repair. The physician documents on his interval H&P that there have been no changes from the prior H&P. He gives the date of the prior H&P, and the date is within the 30-day window. So all of that information about the H&P meets the requirements to use as a preoperative H&P for this case. In the final assessment on the H&P, the physician documents hypertension, chronic AFib, and diabetes type 2 with additional documentation to support the conditions and their medications were assessed during that visit. Can we report these chronic conditions on the operative visit? So I'm going to refer back to this Coding Clinic third quarter 2021, which said that the treatment of the Crohn's did not have to be on the current visit. But does the condition need to require or affect patient care, treatment, or management on the current visit? By the provider pulling that H&P in as part of the current visit by saying, nothing's changed, he wants to use that as his preoperative H&P, does that documentation now support impacting management? So you remember that 2019 Coding Clinic regarding the Crohn's patient, and I said we would come back to this later. Well, this is when we're coming back to it. So as Audrey had mentioned when she was talking about the letters that we get back from, or the responses that we get back from the Coding Clinic, those responses cannot be distributed due to copyright issues. So they're for individual use. We can tell you what the summary of the letter was, but that advice is not official until it is published in Coding Clinic. So our response is unofficial advice. It's just a response, basically. And in fact, there have been instances, and Audrey can support this, where what was published in Coding Clinic ends up being the exact opposite of the advice that we got prior in an individual response. So basically, take this for what it's worth. Bottom line is you have to follow current coding guidelines and what's already been published in Coding Clinic. But I'm going to tell you what the response was, because this adds to the thought process around what is reportable and what isn't. So we sent this exact case to Coding Clinic, and the response that they gave was, in the case published in Coding Clinic third quarter 2019, the provider specifically stated that the patient was receiving treatment for the Crohn's disease. And this is the part we were missing, where I said, I wish we knew what the documentation was. They said that the provider made note of Crohn's disease in the narrative and discussed the medication, indicating the condition was being evaluated, affecting care and management. Therefore, this condition was evaluated during the current encounter, which supports code assignment. So based on just the response, again, not official coding guidance, but based on their response, on this case, I would report the atrial fib because the patient's holding warfarin for surgery. So this medication management is impacting the current visit. But the hypertension and the diabetes, now I'm not sure about those because there's no impact on this current visit, no support and documentation. Dr. Wolf spoke earlier about linkage. So I also want to mention, if this provider had ordered a blood glucose be done on the day of surgery, would you report the diabetes? And if you say yes, then my question is going to be, is there a diagnosis on the order for the blood glucose? If not, how is that blood glucose being linked to the diabetes? Dr. Wolf, I'm going to ask you for your thoughts on this.
Yeah, so I mean, I think there has to be some common sense. And, I don't know, you can't ask me to spell out everything. I would do nothing but document minutia or come up with so many templates that mean nothing that no one could read through my notes. I think in this case, so just to kind of address a question that came up before, if this occurred 28 days ago and I authenticate it today for surgery, that is the H&P for today, right? So, the rules state that, I can co-sign it and say nothing else has changed. So that's the first piece of it. It is if it was written today and we're assuming that they made no changes. I would say also that, from a comprehensive surgical management perspective, I do care as a surgeon if my patient has things. And if I say it's hypertension, continuous lisinopril, I have made an assessment about the control and the impact on surgery. While I don't say, well, patients with hypertension, we got to watch their blood pressure closely during surgery because it may fluctuate. With diabetes, they may have autonomic instability, making their blood pressure more labile. I don't know that they need to say that for me to put the pieces together. And I always say, I will argue for some of these things that get denied, based on kind of common sense and studies. Would ideally, if the physician could link everything, sure. I say that, but I don't necessarily want a chart that goes on forever with things that, are important, but by virtue, if they're not currently a problem, I've looked at the big picture. I know that they're out there. If something changes, I got to have them written down. They're going to impact kind of my risk and prognosis, but I may not have to do anything particular about them during the visit. So I know that was a long way of saying, I would totally vote to report all three of these. And I've certainly been disagreed with before, so.
I totally get your point, Dr. Wolf, yes. Okay, so we're going to move on to our last outpatient scenario, and I'm not going to lie, this one's a little bit painful. So this is another wound clinic visit. Patient has a diabetic left heel wound. In the past medical history, they've listed diabetes, CKD, hypertension, peripheral neuropathy, morbid obesity, diabetic retinopathy, and CHF. Current med list has our insulin injections daily, lisinopril, furosemide, and gabapentin daily. The patient has an elevated BP during the visit and edema to both lower legs. This was documented in the note. The wound is addressed and the patient's reminded to continue their compression stockings. So we know we can code the diabetic wound, but would it also be appropriate to report the diabetic retinopathy and diabetic neuropathy? The retinopathy and neuropathy were not assessed. There's no documentation to support their impacting treatment. Neither of these has documentation to support NEAT. Hypertension was evaluated with a repeat BP because of the elevation on arrival, so this meets criteria for reporting, but what about the CKD? There's no support for NEAT in our documentation for CKD. We have diabetes and hypertension, however. Is the CHF supported? So there are code first notes for I50.9 and N18 point, whatever the fourth character or fifth character is. Coding guidelines state that when there's a code first note and an underlying condition is present, the underlying condition should be sequenced first if known. But if the CKD and CHF are not supported, then how do you code it? So again, I'm going to mention, responses from Coding Clinic. They're not official guidance. They're just responses, basically. But we did send this exact example to Coding Clinic, and the response that we got was, in the outpatient setting, when the provider documents that a patient's condition or treatment thereof affects care and or management for the encounter, the condition is reported. So we don't meet that criteria for the CKD and the CHF. This is consistent with the diagnostic coding and reporting guidelines for outpatient services, and they specify section 4I and J. And they say those guidelines state chronic conditions treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for the condition, and conditions that coexist at the time of the encounter or visit and that require or affect patient care, treatment, or management are reported. So the last line of their response is, this applies to chronic systemic diseases such as hypertension, diabetes, and obesity. So when Audrey mentioned that we would talk about obesity for outpatient, so this response where they're saying that they have even chronic systemic diseases such as hypertension, diabetes, and obesity still have to meet documentation that they're treated on an ongoing basis, that they affect care management for the encounter, so in order to be reported. So obesity here has me a little confused. But if you look at the Coding Clinic for obesity is always clinically significant, it refers us in that Coding Clinic to Chronic Condition Coding Clinic 2007, which is the coding clinic that has both inpatient and outpatient guidance in it. So I'm still a little curious about, is obesity for outpatient always going to be clinically significant? And I wish that in their response, they would have said it applies to chronic systemic diseases such as CHF and CKD, because those are the particular ones I was curious about. So we really don't have a firm answer on this, but you can see why we're questioning this. Dr. Wolf, do you have any thoughts about it?
Yeah, so this again, brings up kind of the difference, I guess, between, and I know we're talking about outpatient only, but in our previous example, when the patient went to the operating room, there was still a lot of hands on deck with a lot of data points that you can argue were relevant to the notes that were being written. In this particular case, I'm going to assume that this was a singular visit with no other support staff, and this is all we have. And if we look at, the physician documenting things that they particularly feel like are impacting care, I mean, obviously we have a diabetic heel wound, right? So we got diabetes in the wound. And the hypertension, of course, was addressed as a one-off because they, repeated the blood pressure. But everything else, I don't know that this physician demonstrated that they cared about it during their encounter for wound care. So I probably would not code those. And I don't think it's perfectly clear that obesity is supposed to be picked up carte blanche, in the outpatient setting. So I might stick with diabetes and the wound. And I don't know that I'd go with diabetic retinopathy because that certainly wasn't, addressed.
Thank you so much, Dr. Wolf. It's great to have that physician point of view standpoint when we're looking at these because, it helps us to think through the process. And then this next slide is just going to be a short list of things that, a checklist basically for you. And it comes down to ambiguous documentation, query your providers. So I'm going to hand it back over to Audrey, and she's going to talk about some inpatient scenarios.
Thank you so much. And I know that we're coming in on the last 5 minutes of this presentation, so I will go through these as quick as possible. In this first scenario, the ED noted that the patient had a past medical history of diabetes. It was not mentioned again during the admission. Patient is not on any meds for diabetes, and the hemoglobin A1C was not ordered. There was no mention of obesity. The BMI was within normal limits. The patient lost weight and doesn't show signs of diabetes. The diabetes is not evaluated or monitored during the 3-day hospitalization. The patient was admitted for a different condition. So with this documentation, and once again, this is an inpatient scenario, where we have stated that diabetes is one of those that we can pick up even in the absence of active intervention. Would it be appropriate to report the diabetes in this case? And then I even threw in another question: if the attending physician would have documented the condition, would that have changed your response to, would you have picked it up? And in the interest of time, I'm going to keep on going and then ask for Dr. Wolf's opinion on this one, because I did want to bring up that even though diabetes was one of those and hypertension was one of those that you could pick up even in the absence of active intervention, there did come out with a more recent coding clinic in 2020 that did talk about history of or resolved diabetes and hypertension. So it is possible with current treatment that this could become resolved. And it's the bottom part of this, the last couple of lines, that it states history of can have two different meanings: chronic condition or the condition no longer exists. So what are they meaning by the history of? In this case, the history codes are assigned because the provider has documented that diabetes and hypertension have resolved and are no longer being treated. Medication was discontinued. Well, when I say that, that's based on this coding clinic. That's not the scenario that I just had. But on this scenario, they are saying it is possible that you could have a resolved condition, and therefore it would be coded as a history of condition. The next coding clinic within the same issue of coding clinic, first quarter 2020, was saying that if the patient did have a diabetic manifestation that was still being treated, like the diabetic neuropathy, and it meets reporting criteria, then you could still, then the resolved condition could still be coded. But basically, going back to the scenario of the one where the diabetes was documented in the ED documentation only, I get concerned with that, because we also know that if you see conflicting or vague documentation available in the medical record, that you may need to query for clarification. So in this case, this scenario number 1 case, may be one of those where you would want to query to get that clarification before adding the diagnosis. Dr. Wolf, what say you on that example of this inpatient scenario number 1?
Yeah, I mean, I totally agree. First of all, and I did bring this up when we talked about it before, but we do not want to tag a patient with a diagnosis of diabetes that doesn't have it. Do you know what that does? Their ability to get life insurance. And I mean, it's just, if they don't have it, they should not have that on their record. These last, honestly, forever. And I don't even know how you'd pull something like that back. And obviously, we didn't have any validation for it. The A1C, we didn't have, no orders related to it. Now, on the flip side, if I was, really trying to sort this out, from what might be in the record, I would look at what diet the admitting doctor ordered. Did they order an ADA diet? So there are ways that we can use that inpatient record to kind of guide us. But again, because this is such a hot button diagnosis for, long-term health risk, I would certainly want to validate it before I, would consider labeling a patient with it.
I think those are such good final comments on this, and knowing that we are at the top of the hour, I'm going to skip through the last 2 scenarios that we had on here. You can take a look at those at your convenience and just kind of have a discussion internally about what would you do in these types of situations. And it is about that of how are we going to label this? And so it is linking up the documentation with the care that's provided and getting the collaboration between the providers and the other internal staff in your facility, because we always do want to take a look at it. What is the chronic condition? Was there any medical decision making that was going towards that chronic condition? And is it something that should be reportable? And so work with your medical staff on this. Dr. Wolf, do you have any closing thoughts on that? And then Bobby.
No, I think it's a lot of material. Thanks for including me.
I agree. Thank you, Audrey.
Great. Well, thank you all to our speakers today. There was a lot of information. A few of you had asked if there's going to be a recording of this. There will be, because we are in transition from our 3M website over to Solventum. There will be more of a delay than usual in getting this webinar uploaded to our site, but it should be there hopefully within the next couple months. I know that's not ideal, but bear with us as we transition over to Solventum. There were questions in the chat that we will follow up with you after to get those answers to you. We really appreciate everybody joining today. We will have at least another quality webinar series webinar in the fall, so we really hope you can join us. So thank you again to our great speakers, and we look forward to hosting you next time. Thank you all for joining.